Hi, my name is Dr. Rachel Morris, and I'm an assistant professor at the Medical College of Wisconsin. Thank you to EAST for supporting our 2021 multi-center trial entitled Development and Validation of a Pre-Hospital Triage Model for the Severely Injured Trauma Patient. The goal of this study is to validate and optimize a model that predicts the need for an emergent intervention within 6 hours of arriving to the hospital based solely on readily available pre-hospital EMS data. The study also uses a mobile application for data input and to assist in decision making. A novel triage model is needed because no existing definitions are agreed upon which define the major trauma patient. Therefore, it is difficult to use pre-hospital data to figure out which patients need the highest level of trauma activation and immediate resources. There is a need to study pre-hospital predictive data elements and combine these elements within a prospective multi-institutional framework. This study will use 250 patients from 10 hospitals to validate the Trauma Intervention Predictive Model, TIP, which predicts the need for an emergent intervention within 6 hours of arrival to the trauma bay. Our inclusion criteria include all trauma patients over 16 years old who are transported either by ground EMS or helicopter and have one traumatic injury. We are excluding all patients who are dead on arrival. The primary outcome is need for an emergent intervention within 6 hours, which include chest tube, intubation, massive transfusion, an operating room or angiography procedure, a neurosurgical procedure, or a central line. This data is collected using a mobile application. The EMS providers will access the mobile application and input the data elements in the pre-hospital setting. This app can also be used by dispatch or the communications center. The app then generates a random patient identifier so that no PHI is collected within the app. This patient identifier then connects the patient's pre-hospital data to the trauma registry. Only 6 elements are needed for the manual collection portion of this study. Thank you, and if you have any questions, please feel free to contact me. My email is listed here, ramorris@mcw.edu, if you're interested in participating or have any questions. Thank you.
My name is Ashley Chapko, and I'm the principal investigator of a 2021 EAST multi-center trial, Breaking Old Dogma, continuation of enteral feeds up to the time of tracheostomy and PEG placement. Malnutrition is a significant problem in the critically ill. However, with busy operating room schedules, we often find that feeds are interrupted repetitively prior to elective surgery. Interruptions are practiced based on the American Society of Anesthesiologists guidelines for fasting intervals for elective surgery. However, these guidelines were not created for critically ill, already intubated patients. Controversy exists due to the theoretical concern for loss of airway and need for reintubation on a full stomach and the consequent aspiration risk. However, multiple retrospective studies have failed to demonstrate any increased risk. It is equally unclear whether the route of feed administration or location of the procedure affects outcomes. We hypothesized that continuing enteral tube feeds in critically ill intubated patients up to the time of both tracheostomy and PEG tube placement does not increase the risk of aspiration and may improve overall nutritional status. We also hypothesized that there is no difference in aspiration events between nasogastric and nasoduodenal enteral feeding routes or operations performed in the operating room versus the ICU or GI suite. We will prospectively follow the patients and collect data from the EMR to evaluate their clinical outcomes, including quantitative nutritional benefits and specific indicators for aspiration. Data will be collected from the patient's electronic medical record and entered onto the AAST Online Data Bank data collection tool. Our goal of this study is to determine if continuation of enteral feeds up to the time of trach and/or PEG improves nutritional status in the ICU and has no effect on risk of aspiration. We will also use our data to explore the safety and efficacy of route of enteral feeding and location of surgery. We hope that you will join us for our study. Please feel free to reach out to me with any questions that you may have. And thank you so much for your time.
My name is Ryan Dumas. I'm an assistant professor at UT Southwestern in Dallas, Texas, and at Parkland Memorial Hospital. I'm the principal investigator in a 2021 East Multicenter trial entitled Intravascular Access in Hypotensive Trauma Patients, an Eastern Association for the Surgery of Trauma Multicenter prospective observational trial using trauma video review. My co-PI is Dr. Michael A. Vela from the University of Rochester, and this study is sponsored by Daniel N. Helena from the University of Pennsylvania. This will be the first multi-center study to utilize trauma video review as a data collection tool. This prospective observational trial will evaluate and compare the procedural speed and success rates of vascular access in patients at risk for hemorrhage. We will also evaluate the association between initiation of resuscitation and patient outcomes. The ultimate goal of this trial is to leverage the power of trauma video review for data collection. This tool really allows us to stop, pause, rewind, and even fast forward videos of trauma resuscitations. This granular level of detail has never before been utilized to examine acute trauma patient resuscitation. We know that approximately 30% of level 1 and level 2 centers across the United States utilize this technology. Using this technology will allow us to very, very accurately measure the time it takes to establish IV access in this patient population. Additionally, we'll be able to study team performance and team dynamics as they care for acutely injured patients. So what exactly do we want to measure? We're interested in studying vascular access in hypotensive trauma patients. In particular, we're interested in studying IO, or intraosseous access, the speed at which it takes to place a central line, or a CVC, and the speed at which it takes to place a peripheral IV. Not only the speed, but also the success rates of each of these procedures. Additionally, we're interested in studying the time it takes to initiate resuscitation, and also the time it takes to make a clinical decision to perform a procedure such as a chest tube or thoracotomy. Additionally, we will collect data on team communication and teamwork. The aims of this study are twofold. One, to determine the time to intravascular access using IO, PIV, and central venous catheter in trauma patients presenting with initial systolic blood pressure of less than 90 millimeters of mercury. The second aim is to determine the success rates of each of these types of intravascular access. For the purposes of this study, the inclusion criteria will be any patient above the age of 16 years old presenting to the hospital in shock that we have defined as initial systolic blood pressure of less than 90 millimeters of mercury. We will exclude patients less than 16 years of age and patients that arrive with pre-hospital IV access in place and do not undergo any additional IV access attempts. The primary outcome of interest will be the duration of each IV access attempt, measured by the start or visualization of insertion needle on the trauma video review, and the access attempt stop time, measured by visualized flushing of the IV access on trauma video review. Additionally, we will study several very important secondary outcomes. This includes the success of each IV access attempt, the median duration of failed attempts, the time it takes to initiate resuscitation in a patient, and the time of IV access placement. We'll additionally measure various administrations of medications, transfusions, and ultimately the time to the next phase of care. We will also measure certain patient-centered outcomes, such as return of spontaneous circulation and mortality. To collect this data, we will use an easy-to-use data collection form that will be shared with participating centers using the REDCap online data collection tool. If you are interested in participating in the study, please contact us. The only really requirement is that you have a TVR or a trauma video review program that is currently in place, and you have the infrastructure to view, record, and collect data from trauma video review recordings. Please contact myself, Dr. Michael Vella, or Dr. Daniel Helena to participate in this trial. We look forward to working together and to improving the ways in which we acutely resuscitate trauma patients when they present initially in hypotensive hemorrhagic shock.
My name is Christina Feather. I am an acute care surgeon at Anne Arundel Medical Center in Annapolis, Maryland. We would like to thank EAST and the Multicenter Trials Committee for the opportunity to share a proposal entitled Wound Management and Emergency Colorectal Surgery to Close or Not to Close. Surgical site infections pose a significant burden on both patients and healthcare systems as the most common hospital-acquired infection in surgical patients and accounting for more than $1.6 billion in direct costs. Colorectal surgery carries a higher risk of SSI, with reported SSI incidences ranging from 5 to 30%. More importantly, indication for operation can further influence risk, as emergent procedures carry increased rates of contamination, metabolic derangements, hemodynamic changes, and longer operative times. Previous studies have suggested that management of skin closure according to these risk factors can decrease rates of SSIs. However, the clinical and economic burden of these variable wound management strategies remains largely unexplored. What is the best method of wound management in emergency colorectal surgery patients, not only for reducing the incidence of surgical site infection, but improving length of stay, follow-up, and other quality metrics relevant to both the patient and the healthcare system? The specific aims for our study will be first to describe the clinical impact of wound management techniques on quality metrics in emergency colorectal surgery, which include but are not limited to SSI, length of stay, length of follow-up, and mortality. In addition, we will describe the variability of practice of wound management techniques in this patient population and its clinical and economic impact. This will be a prospective observational study including all patients undergoing an urgent or emergent surgical intervention for colorectal pathology. We will exclude patients who undergo surgery as an elective procedure or for a traumatic mechanism. We hope that you will join us. If you like any more information on the study, please contact myself, or if you have any regulatory questions, you can contact our research coordinator, Liz Harris. We thank you for your attention.
My name is Lindsay Perea, and I am one of the co-principal investigators, along with Joshua Hazelton, for a 2021 EAST Multicenter trial titled Radiographic Evidence of Delayed Solid Organ Complications, the Red Sox Study. There is no clear evidence as to the necessity of repeat imaging or frequency of interventions in blunt splenic and hepatic injuries, and no definitive recommendations regarding the utilization of repeat imaging exists. Our group recently performed a 2-institution retrospective review evaluating repeat imaging and interventions performed. Imaging was obtained either via the institution's standard protocol or physician discretion. We found that splenic injuries more often underwent standardized protocol scans, leading to quicker identification of complications. Conversely, hepatic injuries were not found to have a difference between scan type. The pilot study was retrospective in nature, meaning that the standardized protocol scans could not be standardized in real time. This study lacked power to characterize the types of interventions and final outcomes. A larger sample size will allow for better understanding of delayed complications and their management. This would assist in clarification of guidelines and creating a standardized algorithm. We will be performing a multi-center prospective observational study of patients of all ages who have sustained blunt trauma to the liver and/or spleen. Our primary aim is to define which blunt splenic and hepatic injuries by AAST grade are at risk of delayed complications. Our secondary aims are to ascertain which patients warrant repeat imaging and when this imaging should be performed, and to identify the incidence of interventions performed for delayed complications found on repeat imaging. We will be collecting data including demographics, vital signs and laboratory values, injury data, resuscitation data, imaging and interventions, This can be collected from trauma registry data as well as electronic medical records, and all data for this study will be uploaded into a centralized REDCap database. Thank you for considering our study, and if you have any questions, please feel free to reach out to me, Lindsay Perea, at my email address, lindsay.perea@pennmedicine.upenn.edu. Thank you.
Hello, and thank you for your interest in joining our efforts to understand and define the safety and efficacy of early initiation of venous thromboembolism prophylaxis in patients with isolated traumatic brain injury. This project will be examining differences in early and late initiation of VT prophylaxis with the hope of demonstrating that early VT prophylaxis is associated with lower rates of VTE without an increased risk of intracranial hemorrhage expansion. We'll also be comparing these outcomes between different chemoprophylaxis agents, as well as outcomes of patients requiring IVC filter placement as an alternate strategy for VT prophylaxis. There is a lack of evidence-based guidelines regarding the timing of VT prophylaxis initiation. The most conservative recommendations support the initiation of pharmacologic prophylaxis within 72 hours of injury. The current ACS TQIP guidelines for VT prophylaxis management after isolated TBI includes initiation of pharmacologic prophylaxis within 24 hours for low-risk TBI and within 72 hours for moderate-risk TBI. High-risk TBI should be managed with IVC filters or by other strategies. This study was designed as a multi-center retrospective cohort study with comparison groups that will define early and late initiation of VT prophylaxis by a 24-hour cutoff from stable CT head. After identification of isolated TBI cases, data will be recorded using a simple data collection tool and a REDCap database to coordinate collection between sites. It is our hope that the results of this study will provide the data necessary to convince surgeons that early VT prophylaxis initiation is safe and effective. Lower rates of VT events and intracranial hemorrhage expansion has 3 benefits in minimizing patient morbidity, lowering costs to patients, and minimizing spending of healthcare dollars. We hope you will consider joining our efforts. Thank you.
Thank you for this opportunity to discuss our 2021 East Multicenter trial entitled Social Determinants of Acute Abdomen Outcomes, sponsored by the Emergency General Surgery Committee, led by Dr. Rondi Gelbard of the University of Alabama and Danhina Santry, a member of that committee. All of us who provide care to EGS patients are familiar with these 2 scenarios. A patient with a strangulated hernia with no medical care and no management of serious comorbidities for 2 decades, and an active 2-pack per day smoker who has no social network to help during the illness or the recovery. Or a patient who knows he has Crohn's but lost his insurance and could no longer afford treatment. His disease progressed and he lost 30 pounds. Both of these patients with acute abdomen are among a large cohort of patients who experience many adverse outcomes, including long lengths of stay, often more than 14 days, a 1/3 or higher rate of major complication, and for the 85 or 90% of patients who survive to discharge, a greater than 15% readmission rate. There are a number of social determinants of health, such as those listed here, that have been shown to influence adverse outcomes for a number of disease processes. These same determinants are more prevalent amongst EGS patients, according to large database reviews. However, the degree to which such determinants are actually present amongst acute abdomen patient populations and how they affect outcomes is poorly understood. Therefore, this trial aims to evaluate the association of social determinants of health and 30 and 90-day outcomes for acute abdomen, as listed here. A secondary aim is to evaluate the association between these same social determinants of health and illness severity at the time of presentation, as can be measured by objective criteria of sepsis or systemic inflammatory response syndrome, as well as clear documentation of a contaminated case in the operating room record. We will be collecting data from our participating sites using a REDCap database where information is de-identified at the site and patient level. Patients in the cohort will have been treated for acute abdomen, which includes a laparotomy within 12 hours of presentation to be consistent with other national databases for the dates shown here. Our exclusion criteria will include prisoners, those without an address listed, and those whose presentation actually reflects a complication from a recent EGS admission in 90 days. Our key predictor variables will be local socioeconomic factors as determined by 3 or 5-digit zip code using the Area Deprivation Index, which is a composite score of various factors related to poverty and other local issues such as food insecurity and housing insecurity. Social support will be determined by case management and social work records. Employment, education history, and source of routine care will be recorded as noted in the electronic medical record. Our outcomes are listed here and will include index hospitalizations such as severity of illness, length of stay, and discharge disposition, as well as complications during hospitalization at 30 and 90 days and readmissions at 30 and 90 days. We've included 90 days because given the long lengths of stay that many acute abdomen patients experience, especially those with adverse social determinants of health that may delay discharge, we feel that the typical 30-day follow-up period that is used for elective surgery may not be applicable to this patient population. The primary research site is where I am located at the Ohio State Wexner Medical Center. Our site lead will be my partner, Dr. Alex Helkin, and our project coordinator is Dr. Holly Baseless. Her contact information is listed here and is at the bottom of all of the slides. Our progress so far includes that our REDCap database is ready for data entry, and our data dictionary has been finalized and shared on the EAST website. Our prior IRB, which did include identifier variables, has been updated to allow for a de-identified multi-site project. We've had discussions with interested parties and have made the decision that because everyone does not have a single IRB process, we will have individual institutional IRBs to participate and have a data sharing agreement. Our targeted timeline is listed here and allows for participation and sharing of final data at the EAST 2023 Scientific Assembly. These are the interested sites so far, and we are excited to have more interested parties contact us between now and the middle of next month so that we can start collecting data in earnest in March. Thank you.
I'd like to thank EAST for the opportunity to introduce our 2021 EAST Multicenter Trial, Contemporary Management of Right Upper Quadrant Gunshot Wounds. I'm Michael Vella from the University of Rochester. My co-PI is Dr. Ryan Dumas from Parkland Memorial Hospital at the University of Texas Southwestern, and the sponsor for this study is Dr. Mark Seaman from the University of Pennsylvania. This prospective observational study will describe the current management strategies for isolated right upper quadrant gunshot wounds and compare the short and long-term outcomes in those managed operatively to those managed non-operatively. Some of the questions that led to the development of this study are: how should isolated right upper quadrant gunshot wounds be managed in 2021, especially because our anecdotal experience suggests that there's relatively significant variability across centers? What are the benefits of non-operative versus operative management in those not requiring emergent operation, if any? And what should be the current management of right-sided thoracoabdominal injuries? A few previous studies have shown that non-operative management of certain abdominal gunshot wounds, including those isolated to the right upper quadrant, is feasible, but less is known about the need for secondary interventions in those managed operatively compared to those managed non-operatively, as well as the longer-term outcomes in these populations. In this study, we aim to compare the short and long-term outcomes in patients with isolated right upper quadrant gunshot injuries managed operatively compared to those managed non-operatively. We want to describe the current practice patterns in management of these injuries. We want to describe the failure rate of non-operative management and identify factors associated with the failure of non-operative management. And finally, we want to identify factors associated with the need for secondary interventions. The inclusion criteria for this study include individuals with isolated right upper quadrant gunshot wound or wounds, age greater than or equal to 18, patients who are relatively hemodynamically normal as defined by the parameters there, and those without diffuse peritonitis. The exclusion criteria include those less than 18 years old, prisoners, those who are pregnant, those with hemodynamic instability or diffuse peritonitis, those with gunshot wounds outside of the right upper quadrant, and those who die within 24 hours of admission. The primary outcome in this study is the need for any unplanned secondary intervention. This is discussed in more detail in the study proposal, but includes things like ERCP, interventional radiology, drain placement, and need for additional operative intervention. The secondary outcomes include a list of predefined admission characteristics and outcomes, again, that are described more in the study proposal. We also want to look at 6-month functional and mental health outcomes as measured by the PROMIS 29 profile metric. Upon completion of appropriate data share agreements, all data collection will be done through a centralized REDCap database. We are really excited about this study and do feel like it will contribute to the knowledge base on the management of isolated right upper quadrant injuries. If you're interested in participating, please contact myself at the email listed there or my collaborators, Dr. Ryan Dumas or Dr. Mark Seaman. Again, I'd like to thank EAST for their support with this multi-center trial. Thank you.